Hey there. Welcome to the second condition lecture of 3, and this is part 2 of 3 of this lecture. And we just spoke about cerebral palsy. Now we are going to move on to genetic disorders. Just a brief review. There's 46 chromosomes in every human. That means 23 pairs, one from your biological father, one from your biological mother. There are about 30,000 genes per chromosome. There are 23 from dad and mom, which I said. And if fertilization occurs, these pair, and so we wind up with 46 via a process of meiosis. When we think about conditions that affect children that are chromosomal in nature, there's a few different things that can happen. One is monosomy, which is there's only one chromosome rather than a pair, and typically these children are non-viable. In other words, they do not make it to birth. There may be non-disjunction of autosomes, so there's an unequal division of chromosomes when the cells divide. A trisomy is the most common, and Down syndrome or trisomy 21 is an example of that condition. There may be missing chromosomes. These children are typically non-viable, or fetuses are non-viable, except in Turner syndrome, which is an XO chromosome. So 1 from the mom, 0 from the dad. Deletion is missing a portion of the chromosome, and translocation is when a chromosome breaks off and reattaches elsewhere where it's not supposed to be. Some examples of conditions, as I said, with the trisomies, we have trisomy 21, which is Down syndrome, quite common, and we're going to look at that one. Edwards syndrome, trisomy 18, and Patau syndrome, which is trisomy 13. In terms of deletion of chromosomes, Cri-du-chat is one of those conditions, and it's deletion of a part of chromosome number 5. It's called Cri-du-chat. That's French for cry of the cat, because when these children are very young, their cry sounds a little bit like a cat crying. And then non-disjunction of sex chromosomes, Klinefelter syndrome, we have an XXY instead of XY. And there's also an XYY, which I think is referred to as like a super male pattern. Now we're going to talk about Down syndrome and trisomy 21. And if you look on the slide, you'll see at in the bottom row in the middle, there are 3 chromosomes together. That is the 21st position. And you can see that for this child, there are 3 portions. So that's what it looks like. There's also some videos that I've linked, so have a look in the presenter notes, check those out to get, again, an idea of what Down syndrome looks like in action. It's one thing to hear about it and see pictures, quite another thing to watch videos. So please avail yourself of that. And you can also go to my YouTube channel, Melisa Kaye, Google Melisa Kaye YouTube, and you'll come up with me, and I have many, many examples of various conditions. All right, so here are some of the main signs and symptoms of Down syndrome. There are a number of physical impairments. There's also mental impairments, so intellectual disability. There are some significant health issues, some initially, some over time and throughout the lifespan. It occurs in 1 of 660 newborns. So we had about 1 to 2 in 1,000 for CP. This is even more frequent. It more commonly occurs in older mothers, but not exclusively. And just to give you an example, if you are giving birth at 30 years of age, you have a 1 in 1,000 risk factor. At 45 years, your risk goes up to 1 in 30. Now digging into some of the common characteristics of Down syndrome. There is hypotonia, meaning low tone or floppiness, and hypermobility of the joints. And those are some hallmark signs of Down syndrome. Short stature, poor mouth closure at rest and some tongue protrusion. In other words, the tongue sticks out a bit. And both of these may be outcomes of that hypotonia, right? So low tone, including the face, leads to this lack of jaw closure and the tongue wanting to stick out. Individuals with Down syndrome also have broad hands and short fingers, and they have something called a simian crease, which means if you look at your hand, you have typically a crease up here, a crease that comes over here, and a third crease that comes down and around the thenar eminence. In individuals with Down syndrome, they have a single crease that goes across like this. Part of what happens with that is that it's more difficult to develop the muscles of the hand and the coordination of the hand because we have less arches to help form the hand into different positions for functional use. Individuals with Down syndrome also have almond-shaped eyes and often epicanthal folds, so that's a second fold of skin along the corner of the eye. They may have a flattened back of the head, low-set ears, and cognitive impairments that range from mild to severe. In terms of medical issues, there can be cardiac abnormalities that need surgical repair at or shortly after birth, or further down the road, cardiac issues that develop throughout the lifespan. There's something called atlantoaxial instability, and the pictures in this slide are of atlantoaxial instability. So we have the top of the spine, right, which has a vertebra that points up and a ring that goes around it. Yes. And in children with Down syndrome, and this is not everybody, that connection can be fragile, right? So my understanding is that it's not as well formed, and so it's not as secure. What this means is, and students often think, oh my goodness, well, they can't participate in gross motor. I am here to tell you that children with Down syndrome and adults with Down syndrome can absolutely participate in a range of gross motor activities and sports. What we want to avoid and want to be careful of are things that put direct pressure on that atlantoaxial junction, things like tumbling or contact sports like tackle football, okay? So be aware of it, but it doesn't mean shy away from doing motor activities with clients who have Downs. All right. Also, a weak immune system, gastrointestinal issues can happen, vision and hearing difficulties, and you'll often see small children with Down syndrome who also have glasses, and a tendency to obesity. Moving on, we're going to look at Prader-Willi syndrome. Excuse me. The defect is in chromosome 15. It's a 1 in 15,000 occurrence. Again, short stature, obesity. With Prader-Willi, there's an insatiable appetite. So that's a little bit of a hallmark. Moderate, this should say intellectual disability. This is an old slide deck. We'll just say ID. Hypotonia, again, a narrow face with almond-shaped eyes, but notice that the face looks quite a bit different than that of someone with Down syndrome. Poor thermal regulation, so not good hot and cold control, and underdeveloped sex organs. Next up, Williams syndrome. This is a microdeletion on chromosome 7, 1 in 20,000. Physical characteristics, again, these almond-shaped eyes, small pointed ears, kind of elfin, a wide mouth, and an upturned nose. There's intellectual disability, and these children are very easily distracted. So attentional difficulties are a big part of this, especially as kids move into school years. There's severe visual perceptual and visual motor issues. And I've actually worked with a couple kids with Williams syndrome, and this is marked. It's very interesting where the challenges kind of fall out in these different syndromes. There are also some motor impairments, but very interestingly, there's a couple strengths in kids with Williams syndrome. One is that they have extremely good musical ability and social skills, and they're also very friendly and socialize very well and easily. So this musical ability is kind of crazy and cool, and very engaging. And so when a child is very engaging, that's awesome, right? It's a strength, but it also can kind of enable them to compensate for some of these more frank deficits. Next up is Neurofibromatosis 1, also known as Recklinghausen's disease. So this is an autosomal dominant disorder. There's a growth of multiple tumors on the central and peripheral nerves. There's cafe au lait spots on the skin, so a very light brown spot. There's pain due to these growths along the nerves, and it results in nerve damage that affects sensory and motor systems. There's mild, sorry you guys, mild intellectual disability and learning disabilities, and this disorder occurs more often in boys than in girls. Here we have our second prep for class thought question. Skipping ahead. You are treating a 7-year-old client with Down syndrome, and the question is, given what you know about Down syndrome, the signs and symptoms, what functional limitations might you see in the following areas? ADL participation, play, and school participation. So think about that. I'm going to show you 4 other slides that are for reference only. So if you're a person that's interested in genetics or think that you want to work with this population, it's a resource for you. We have autosomal dominant and how that happens with genetic conditions, autosomal recessive, X-linked dominant with an affected mother, and X-linked recessive with a carrier mom. That completes part 2 of Conditions Lecture 2, and I'll see you real soon for part 3. Thanks, everyone.